Hello, I'm Michael Sisti. I'm talking to you from my office on the 4th floor of the Neurological Institute of New York, Columbia University Irving Medical Center, New York Presbyterian Hospital. Today I'm going to talk to you about the most difficult topic and the most challenging problem in my practice and potentially in your life and those of your family members. I'm going to talk about the treatment of malignant brain tumors today. So let me just discuss a little bit about how a neurosurgeon approaches this topic and what the process is for somebody who's been told the most terrifying thing, that they have a brain tumor. So generally, how do patients come to me? Well, it's interesting. There's two ways. One is a dramatic way. For instance, perhaps a tumor growing within your brain has caused a seizure, which is something that will usually wind you up in an emergency room, and a diagnosis from an MRI or CT scan will be made there. Occasionally, it's bleeding into a tumor, and that also winds up in an emergency room, in which case everything comes very hard, very fast, and it's extremely confusing. One minute you're pretty much okay, and the next minute you're in an emergency room and somebody's telling you something that you're having a lot of difficulty believing is true. And so those patients, if you happen to be one of those patients, in some ways your seizure or other acute presentation can be an advantage, because that might lead to an earlier diagnosis for you, and we may have more effective treatments based on size and location to safely diagnose and remove your tumor and then treat it after surgery with what we call adjuvant therapy, which is just a doctor's way of saying most likely radiation and chemotherapy. Perhaps clinical trials or experimental therapy might be added to that as well. The other way is much more subtle. Many brain tumors, particularly in older patients after the age of 50, may occur in regions of the brain, particularly the frontal lobes or the temporal lobes, where there's a collaboration between the lobes on the right side and the left. And occasionally a tumor can grow very slowly over a period of months and achieve a very, very large size with extremely subtle symptoms. And this shocks my patients sometimes when they come to me with a scan in which they've been told they probably have a brain tumor and it may be malignant or cancerous. It's hard to believe that many of the things that you or your family member have been observing over the last 6 to 9 months have finally come to this conclusion. Because although brain tumors can be fast growing, if they grow in an area that's not critical, the symptoms can be extremely subtle. It could look like a depression or withdrawal. It could look like substance abuse. It could look like a thyroid problem or nutritional deficiency, something that affects your general overall health. And because patients, who are older have multiple medical problems, things like dementia, other kinds of medical problems that affect personality, behavior, particularly psychiatric disturbances like depression or endocrinological problems. I think the classic one would probably be thyroid problems, which are fairly common. That many of the symptoms you have may not really be obvious in the very beginning, that something is brewing there that is very dangerous. And so patients who have tumors in their frontal or their temporal lobes may have very large tumors by the time they come to see me, and many patients have a history going on for a number of months. Patients are really upset about this, and I can understand why. But one of the features of a brain tumor, which can make this not a negative for us, is that if you have something that's in a surgically accessible area of your brain, like a frontal lobe or a temporal lobe, that we can do a very safe job, generally in terms of making a diagnosis and removing, if not all, but the majority of your tumor, is that this tumor doesn't really have much of a capacity to spread within your brain or to leave your brain to go any other place of your body. So timing for your outcome may not be as critical as you might think. Some people feel that so much time has gone by and they have so many difficulties that perhaps there's no real option to help them at that point in time. That's usually not true. Unlike, let's say, breast cancer or lung cancer, where that disease causes a lot of problems for patients because of the spread of the primary tumor, let's say your lung or your colon, all over your body. Brain tumors don't really spread. They don't spread essentially within the brain, and they almost never leave the brain to go anywhere else. So even if you've had symptoms for a period of time and you're concerned about the delay in diagnosis, it generally doesn't affect your outcome or your treatment as much as you would expect. Look, in general, we'd like to meet you as soon as possible, but it has less of an overall effect in my personal dealing with these kinds of tumors over the last 30 years than many other kinds of tumors which you might be more familiar with. In general, when we're talking about tumors in the brain, you're going to hear numbers, what's called a grading system. Many of my patients have been to Dr. Google, and there's nothing wrong with that. You'll learn some of the vocabulary and the lingo that goes along with this, and many of my patients latch on to the grading system because it's pretty clear. Pathologists who grade these tumors look at a scale of aggressiveness from 1 to 4. It's interesting, here at Columbia, before we used the World Health Organization grading system, we generally looked at brain tumors in 2 broad classes: slow-growing tumors and faster-growing tumors. If you wanted to just look at those numbers and just combine them, you might say somebody with a 1 or a 2 type brain tumor is something that we would consider a relatively slow-growing tumor, and somebody who has a 3 or a 4 has a faster-growing tumor. I think the public conception of what is malignancy or cancer fits more with tumors in the 3 and 4 description than the technical descriptions we use of the 1 and 2s. And these tumors tend to involve different kinds of patients. For instance, I'll do the slow-growing tumor analysis first. And so generally, patients who have slow-growing tumors are generally younger, people in their 20s, 30s, and 40s. The tumor may be very large and have grown over a long period of time. And sometimes my patients look at the scan and say, "Dr. Sisti, that just can't possibly be my scan." I said, well, look, you have a slow-growing brain tumor that's growing 1/4 of an inch or so a year. Over a period of 10 or 15 years, your brain could adapt to that, particularly if your brain is younger and more flexible. And I usually say there's a paradox. Sometimes the younger you are and the bigger the tumor is, probably the less aggressive in terms of its growth rate that tumor might be. And there's some real tip-offs for that. If you walk into my office here in the Neurologic Institute and you come in with your family members and it's hard for me to tell which person I'm looking at actually belongs to the scan I just looked at, that's probably pretty good for your prognosis. It means you and the tumor have been growing together over a long period of time, and even though it's very large, if you're neurologically in good condition and you're young, these are very important positive factors for your outcome, or your prognosis as we call it. Secondly, when we look at your MRI scan, when you get an MRI scan, it comes in 2 parts. There's an initial part, and then somebody comes in, a technician or radiology technician or a doctor or a nurse will come in and give you an injection of contrast. Contrast is a proxy for rate of growth. So when you get that injection in your veins and it goes into your body, if some of it gets hung up inside the tumor, it'll look like a white spot on your MRI scan. And the way MRI scans are formatted, the brain looks kind of gray-black, and when the contrast looks white by convention, and if we don't see any enhancement, as we call it, that's the white spot on the MRI scan, then pretty much you probably have a slow-growing type 1 or 2 brain tumor. It may be very large. It may have been there for a long period of time. And generally, this group of patients has the best prognosis and quality of life of all the patients I deal with brain tumors. The question really comes up is, well, if that's true, why are you seeing me? Well, sometimes there's what I call the wolf in sheep's clothing. Occasionally, your brain's a better detector of a change in the tumor than the world's best MRI scan. And what I mean by this is, if you've been living with a slow-growing tumor without you knowing about it for many years, as you get older, we don't know exactly why this happens, but this is not an uncommon event in patients with tumors like this. Occasionally, the tumor will change its rate of growth. And usually it's going from what I call a 2 to a 3, from something slow-growing to something moderate-growing. But it's happened so early that your brain picked up the problem before the MRI scan did. It means that maybe you had a seizure, or maybe you had a really bad headache, or another neurological kind of problem. The MRI scan is done. There's a large lesion inside your brain proper, and yet there's no swelling. Neurologically, you look really good, and there's no contrast enhancement. Well, that's something that's pretty good for us making an accurate diagnosis for you and getting you the best possible result with surgery and with other things we might refer once the neuropathologist makes the diagnosis. Now, I can't emphasize how important it is, how critical it is. Everybody, of course, in the beginning, it's like first contact with an alien civilization. You're speaking to Dr. Sisti, a neurosurgeon at Columbia in New York City. I mean, it's scary, and somebody's told you had a brain tumor. I can understand why this is really difficult to absorb because everybody's in a state of very high anxiety and panic. You're terrified. We understand that. Part of my job is, if you have what I believe is a slow-growing tumor, is to emphasize that the positives of this, and to say that the key thing about this surgery, I'm just going to assume that the techniques of the surgery, the advanced computer techniques, the things we use in the operating room, intraoperative imaging, ultrasound, fluorescent dyes, sonication, all the technical things of the surgery. I'm just going to put that all aside and say, I think if you knew what I did, the most important thing to me in that surgery is to get the diagnosis right. You need world-class neuropathology in real time to do this. People who have dedicated their entire lives to looking at small pieces of your brain and telling me right then and there during your surgery what it is I'm operating on. You would be shocked to know that many of these tumors look exactly the same to me at surgery. All the technical medical names you're reading about on Dr. Google, astrocytoma, glioma, oligodendroglioma, you know, there are a lot of similarities physically in these tumors in surgery. I can't see the cellular makeup of these tumors with my eyes or even under an operating microscope. But right there in our operative core here at the hospital, we have world-class experts who will look at your tumor in real time and give me a heads up about what it is we're operating on. And this is important for me to know in surgery, but also you and your family members are waiting that day to hear from me what it is that you have. And our pathology here is so good that almost always, I can't say always, but obviously they have to look at everything. It's up to the neuropathologist to say what your diagnosis is, not the surgeons or the neurologists or the neuroradiologist. It's really a neuropathological diagnosis. But I have a tremendous amount of confidence in the doctors that I work with here to do these very important analyses in real time, and then to do the extra work that needs to be done in their laboratory, looking at the genetic makeup of the tumor and what we call the marker analysis. Now, some of these things are very routine and could be done just about anywhere, and they have a lot of implications about your prognosis. I mean, no two brain tumors are exactly the same. I mean, it kind of intuitively makes sense. You know, no two brains are the same on the planet, so it's no surprise that there are probably some unique features about your tumor that may be different from somebody who has the exact same diagnosis as you. And so we can tease some of that out by doing genetic analysis and analysis of certain kinds of enzymes and chemicals that are associated with these tumors. And some of these markers, as we call them, are very helpful to give us an idea about your prognosis, about how to direct your treatment. And so not only the neuropathologists that are dealing with these tissues, but the people who, they're technicians, who are working in their laboratories doing these very advanced analyses, and the research community that also gets this tissue to do next generation sequencing and some other things we might ask them. You know, they have to be every bit as good as what they're doing as what I'm doing in the OR. And you know, if you need the surgery, because I think the surgery can be done with a degree of safety and to get an accurate diagnosis, I cannot possibly do this without world-class neuropathology, and that we have here. Many of our neuropathologists here are NIH funded or deeply involved in the primary basic science research of brain tumors. They live and breathe this stuff every day. They come to our conferences every Thursday to justify their findings to us and make suggestions about things that they know that neurosurgeons wouldn't know because we travel in different worlds. And the community of world-class neuropathologists is very tight. Great doctors in New York speak to good doctors in California or Europe or Asia, all around the world, sharing information, research material, publications. And we rely so heavily on our neuropathologists because if we don't get the diagnosis right, and this goes both for slow-growing and fast-growing brain tumors, then we're not treating exactly what it is you have, and we can lose valuable time and important treatments that you might need without a really accurate neuropathological diagnosis. So with world-class neuropathology like we have here, we can get the answer as best as anyone can, in my opinion. And this is the basis of how we're going to work with the next group of doctors, neuro-oncologists and radiation oncologists and people in the research community to figure out, of all the choices we have for your tumor, which one works best for you. Because although your tumor may have the same name as some other person, there are probably some differences between your tumors. And we would like to exploit those differences. People call it precision medicine, or sometimes they'll use a mathematical term saying N of 1, meaning that you're a person of 1. And yes, all brain tumor patients share things in common. But the things that are different are things that we can have some leverage against your tumor. And to get that right, we've got to get it right with the neuropathologist in the OR. And here we've done some great work using fluorescent dyes, doing some great published research work about the tumor actually doesn't have the same DNA or genetic makeup depending upon where you sample it. So how you sample these tumors, we call it annotated biopsies, meaning that if I'm doing a biopsy of your brain, well, the North Pole genetic information may be different than the South Pole, may be different than the east side, the west side, than the bottom, than the middle. And so generally when we're doing these biopsies, technicians will come to the OR and we will actually localize the specific exact location, the street address, the zip code of where the biopsy came from. And so that we have an idea about the heterogeneous or diverse genetic makeup of your tumor, because these tumors are not exactly all the same. And so just having one simple look at your tumor may not be enough to give you the right information. So the communication with our neuropathologists here is extremely good. They call me and ask me questions about your history, about the scans, about what I thought during surgery, the location of the sample. And then once a week on Thursday mornings here at Columbia, all the doctors, my neurosurgeons, neuro-oncologists, neuroradiologists, neuropathologists, research people, students, get together and we try and come up with I call it a story, fit all the pieces of the puzzle together, a narrative, your history, your age, location, size, the extent of the surgical resection, the result of surgery clinically, how you did, the name of the tumor, its molecular and chemical characteristics. And we add that whole thing together. How do we make a story that we can explain to you that based on all this complicated stuff, that we have something that we think works best for your particular situation at this point in time. And that's not really how I would, just my opinion. What happens is you meet your surgeon, you trust your surgeon, you have the surgery, you have the best possible outcome. You look to your surgeon as the person with the answers. I wish I had those kind of answers. I have certain kinds of answers that are, sometimes I tell patients, look, this is in some ways it's like a hurdle race. We got to clear that first hurdle. We've got to get over that one first. We've got to get you through the surgery, get out as much tumor as we possibly can, get a proper diagnosis. But the other hurdles, I need specialized experts for this. So while you're in the hospital recovering from the surgery, we have a full-time neuro-oncologist who's a hospitalist. And she comes around and sees patients, she introduces herself, she's seen your scan, she's talked to me, she has a preliminary idea of the information, she gets a sense of you and your family as people going through this. And then when we go to the conference, it's not only just myself that knows who you are and what your situation is, and gives some context to the whole thing we're going to recommend to you, because that's important. But we have somebody who has a different kind of experience than me, a medical experience from the oncology perspective. And then when you come back the next week to have your staples taken out and your medications adjusted, usually it's on a Thursday, sometimes it's on a Monday, then you'll meet one of our neuro-oncologists who works here in this building with me. And those neuro-oncologists are dedicated to their office practice. And generally what we try and do is match your specific tumor to one of our full-time office-based neuro-oncologists, because neuro-oncologists, like neurosurgeons, they have different interests and expertise, they have different research interests, different clinical trials, and so of course we have a sense of this. So we know that maybe in your particular situation, neuro-oncologist A would probably be better match for you than excellent neuro-oncologist B or C. So this way, when you come back to have your staples out, we can get you to see the neuro-oncologist that day, and we've matched you with a person that has a real interest and expertise in dealing specifically with your problem. So not a generalist in neuro-oncology, kind of a specialist. Additionally, I work with a superb radiation oncologist and have for many years. We're co-directors of the Gamma Knife Radiosurgery Center here, Dr. Tony Wang, but he has also excellent other colleagues in radiation oncology. And generally, we try and get you to see a radiation oncologist if necessary the same day, so that I call it a big day at Columbia because you're getting the final results of the pathology. I'm taking out your staples. You may be meeting with a neuro-oncologist and radiation oncologist. So, from the week that you met me and had your surgery, because surgeries are generally done within the week of you meeting me. Sometimes I'll admit you from my office, but whenever, these surgeries can't really wait in most cases, although they're generally not emergencies. I mean, if you have a brain tumor and somebody tells you you need surgery, no one's ever going to convince me you shouldn't have that surgery as soon as possible, because that's how I would feel about it if it was me or anybody in my family. And sometimes it has to be on a weekend, and that's fine too, because we run a regular neurosurgery schedule here on weekends and have the same ORs, the same anesthesiologists, and the same excellent neuropathologists show up whenever we need them to show up to get this done as soon as we possibly can. You can't really wait on this either emotionally or medically. So that day, let's just say you saw me on a Monday and you had surgery the same week, and then you go home by the weekend. If you walked in the hospital, generally, you're going to walk out. I like to say everybody's circumstance is a little different. I'll go over that a little bit as I talk about the more aggressive brain tumors. But within that week, we really want to know, okay, what's your diagnosis? We want to get as much as we safely can because we know that makes your prognosis and quality of life better. And we want to have a plan. This is so complicated, and there's no real consensus among the best doctors anywhere about exactly how to do it the same way for each person. And that makes sense because you probably have a unique tumor. But we want to clarify this situation for you, give real clarity to it, and say, this is what you have, and this is what we did, and this is what our doctors thought was the best course of action for you, and this is when we should start and where we should start. Now, of course, obviously, there are other excellent doctors, and we encourage second opinions if that's what you need, and we work with every good doctor you can think of, wherever they are in the country, and patients who come to us from different parts of the country or the different parts of the world. Of course, you're not going to come back here, most likely to New York for your treatments, and we'll work with your doctors wherever they are, any state in this country, anywhere in North America, Europe, or Asia. No, of course, we know all the doctors have similar experience to us, both in surgery and radiation oncology or neuro-oncology, and there really isn't, our reach is global. And so, and it's local too. We know all the good places locally that we like our patients to collaborate with. And so, because for some patients, it's very difficult to get here. So we have to figure out a way to make this work for you. And so we're very dedicated with that. And usually within that 7 to 10 day period, we've got the plan. And then of course, if you want to get some confirmation of that, we know how to help you set that up, about how to get your slides or your scans to wherever it is that you need to get them to. Wherever you think is the best place for you is where I think is the best place for you. Of course, it's a great place, and we want our patients to meet our doctors and kick their tires and see if that works for them. But if it doesn't, that's okay too. We'll help you. Whatever it takes to get you and your family members feeling that you've got the right team of doctors on your side, that's really all I'm interested in, actually. So that's basically the general introduction. Now, there's another class of brain tumors. These are the faster growing ones, the 3 or 4s, what we call high grade. And so the brain is made up basically of very few kinds of cells, but the two basic building blocks of brain tumors are not really the cells that you think of your brain cells, which are called neurons. It's the cells that are supporting the neurons. Depending upon where you went to medical school, an important supporting cell could be called an astrocyte or a glial cell, in which case you would call a tumor of that an astrocytoma or a glioma. The most aggressive type of glioma is a glioblastoma. That's a type 4 brain tumor. A type 3 brain tumor, it's got a fancier name, kind of. It's called an anaplastic astrocytoma or glioma. Although we treat them very similarly here, there are some differences. The other cell is the cell that wraps your brain cell in insulation, because brain cells, to communicate with one another, send electrical chemical signals to do their job. And so just like any wire that you have in your house, there has to be some insulation, and that insulating cell, it's a mouthful. It's called an oligodendroglioma, and we call those oligos short. And actually, in my experience and many other doctors, the oligodendroglioma type tumors have a much better prognosis, I think, if certain kind of genetic markers are present. So nobody likes to say they have a favorite brain tumor, but a slow-growing oligodendroglioma or an anaplastic oligodendroglioma, we've been very good in this century at converting a very dangerous disease to what I call a chronic condition, something that I don't think we could say we have cured you, but we treated you to the point that the tumor, you may have a normal scan, you may have a normal quality of life, you're in what we call remission, and we want to make that remission last as long as possible for you. And in my personal experience, I've seen, especially in younger patients or middle-aged patients who have oligodendrogliomas, some really amazing outcomes, some triumphs of advanced doctoring and the human spirit and family support. I mean, it's the kind of thing that keeps you going. to do better every day, quite frankly, not just me, but everybody I work with, because we know we've moved the bar quite a bit on this particular tumor. Our greatest challenge, of course, by far, is the glioblastoma. So this generally tends to be a person who's older, person anywhere between mid-50s to even the 90s. And so this particular disease is what most people think of when they think of brain cancer. And unfortunately, it makes up a fair proportion of all patients who have cancer in the brain. And so a lot of decision making goes into this, and most of the critical stuff about what we're going to do usually starts preliminarily with your surgeon. So in a disease where no one that I know of has a cure, but we have a lot of treatments, one thing we want to do in a difficult situation like this is we're looking to optimize the benefits of treatments and to reduce the risks. It's possible that, depending upon your age, your medical problems that you may bring to us, we call them comorbidities, the size of your tumor, your neurologic condition, I don't really have any interest as a neurosurgeon or as a person to make your bad situation worse for you. And so sometimes less is more in a particular situation like this. And that's a very difficult thing to discuss, but overall my feeling as a neurosurgeon in treating malignant brain tumors like glioblastoma is that, and obviously you can get other opinions, but I really feel like I'm adding value here, that you're coming to me with something that I can get, if not almost all of your tumor out. That'll really make a difference for you. That'll make a diagnosis, make the quality of your life better, extend your survival, and your quality of life. So first off, I'm really looking at you somewhat through the lens of a surgeon, not the lens of a person, let's say. Is your tumor surgically accessible? Accessible means to me, unfortunately, many of them are accessible locations, like in your frontal lobe, your temporal lobe, your occipital lobe, as opposed to the deep central core of your brain. If you've got a tumor that's close to one of these particular areas, and I feel we can pretty much remove the majority of it, then surgery is really going to help you a lot, both in the short and the long term. But if it's on both sides of your brain, or if you're coming to me with your family members and a lot of neurologic injury has already occurred to you, and it doesn't look like surgery is going to help you very much, I'm not saying we wouldn't do a biopsy or a subtotal resection, but generally to push surgery in this particular situation is a really difficult thing for somebody like me to want to do. And of course I've done it. Sometimes I said, wow, that was, I overestimated how difficult it was, and I got a much better outcome than I thought it was ever possible. But sometimes, of course, it's the other way around. And so it requires a lot of communication between really honest, direct, frank communication between you and your family members about what are the goals of treatment here? What are we really striving for? And so you would need the guidance of a surgeon in the beginning to really answer those questions for you as honestly as that surgeon can from that surgeon's own particular experience. And there really isn't a consensus among surgeons about how to do this. So always good idea to get other opinions, in my opinion. And nobody really has the solution to this surgically. And so I think it's honest to say that you need to feel comfortable with my style of this kind of practice if you want to have your surgery done by me at this hospital. But and that may work well for you, but if it doesn't, I'm perfectly okay with helping you find other people that might work better with you than I would. But let's say that you're like most of my patients I see with glioblastoma, and I think that surgery can be done safely and effectively and give you the best possible outcome, then we're going to try and get that surgery done as soon as possible. And we're going to try and get everything out we possibly can. And of course, there's some techniques for doing this, and they're not exotic, but they may sound exotic to you: the use of computer navigation, intraoperative imaging, special kinds of dyes that can be used under the microscope. There's a whole host of them. But my feeling is, ultrasound is another favorite, but my feeling is yes, getting the surgery right is really important, but as I discussed with the lower grade tumors, getting accurate, fast neuropathological diagnosis and involving the neuropathologist while you're there in the hospital recovering from your surgery is critical. And then connecting you to the team of people we work with, which you will find out very quickly. You'll enjoy meeting your doctors and talking to them about strategy. You're going to find out the nurses are doing most of the work, thank God, because our neuro-oncology nurses and our nurse practitioners that work with us here are experts on this. And when we're in the operating room or inaccessible to you, the person who you're going to be speaking to many times will be someone who's really doing the day-to-day management, checking on your blood tests, making sure your meds came in right, scheduling your scans, crying on their shoulder a little bit. I can't tell you how good our nurses are in neurosurgery and neuro-oncology who specialize, like we specialize in this. They develop tremendous expertise about, particularly in things relating to getting your medications at your pharmacy and your blood tests and your scan scheduled. The doctors are focused on their technical expertise and those kinds of things, as we should be, but there are lots of little things that need to be filled the cracks in, and they're not unimportant. They're actually extremely important. And so the glue that holds this whole thing together, it's every bit as important as your doctors, is the excellent clinical nursing staff we work with. They're heroic, all of them, and they'll become part of your family. You'll see. It's something that's essential in our educational and patient care process to have the right kind of in-house nursing backup from nurse practitioners, many of whom are involved in research, to be there when we can't be there for you because we're in the OR. And so you'll get to know the nurses very well, and you'll come to love them like we do. So we'll get you through the surgery. We'll get you through an accurate, precise diagnosis. We'll get a tremendous team of people that are not only world-class in their abilities and have published and are leaders in their fields respectively, but also people who you can rely on emotionally are there to help you, because we know how difficult and stressful this is for you and for us. And we all have to be on the same page and work together as a team to try and optimize your chance for a good, long-term, high-quality remission, which is what we're striving for in the absence of a cure. If somebody comes up with something that's a cure in today's day and age with the internet, we would change in a day, in an hour, in a minute, in a second. If someone has a better idea than we have, or comes across, which this is an area of extremely active, high-level funded, research-funded abilities by many excellent people across the globe right now. And this field changes so rapidly, no one person can actually keep up with the advances, mostly having to do with precision medicine and genetic testing and improved drug therapy and radiation techniques. And so this is a field in which every couple of months things change. And you really need to work in a place, as good as you are at what you do, you can't possibly cover all the bases. You need, that's what they mean by the team. And sometimes I see my patients there, they want me to, I understand it, it's natural, you want me to understand your genetic markers or one of the 27 different protocols we're offering here for the particular type of tumor you have, but I'm learning like you're learning from other experts in real time, because sometimes something comes up so quickly that even I haven't heard about it yet. And every now and then some of my patients hear about it before I do, and there's nothing wrong with that. I get a lot of good pointers from my patients about what's going on around the country at the best hospitals and what my friends are doing to try and help. And we do collaborate with the best hospitals in the country, and so we can use that to your advantage. So it's a difficult topic because what we're all seeking for is something we don't have yet, which is a cure. A cure like we have for appendicitis with surgery, or bacterial pneumonia, something that we know that we're going to give it to you, it's not going to come back, like we do with, let's say, some types of meningiomas or other exotic benign tumors that we deal with. This is much more challenging and complicated with that. But depending upon the size of the tumor, your age, location, the extent of surgical resection, the genetic markers, and many other factors, we're doing much better than we ever did, and we're committed to doing better every day. And you're an important part of that, you and your family. And as gut-wrenching and as difficult as it is for everyone, if you're the kind of person we think we can put in remission, we will leave no stone unturned for you. We'll do whatever we can possibly do. I just don't want to do anything that shouldn't be done. I think you need to believe in what you're doing is right, and the golden rule. I mean, would I put myself or somebody that I love through the treatments we're proposing? And I could be overruled on this. Maybe you feel differently about it, or my colleagues do, but I've always been pretty honest with my patients, for better or worse, about what my philosophical approaches to this, and maybe that's been helpful for some patients. It's been helpful for me, because I feel I should tell you as nicely as I possibly can the worst of all possible news for you and your family. But we'll be there for you, and I won't be the only person there for you. Our excellent doctors and nurses, hospital, we're all there for you, and we'll keep getting better as time goes along. And you can play an important role in that for us. So, difficult topic. Sometimes people say, why am I still doing this? And I think it's because I think this is where, this is not a technical thing. Surgeries on complex benign tumors that are, you know, in and of themselves could be life-threatening in terms of the techniques of the surgery and so on and so forth, the things that kind of surgeons are really interested in, including myself, obviously. But I know this is more of a medical disease and a personal disease, and it goes to why I went into medicine maybe in the first place. And I've been fortunate to work in a place that never shied away from dealing with difficult and impossible problems. And you know, it's only, as someone once said, it's only impossible until somebody shows you that it isn't. I've seen that many times in my long career here, and I'm living for the day that that'll be true for this disease as well. Thank you very much for listening to this, and I hope you find some use in this for you and your family members. If you would like to talk to me or anybody in your institution, please call us, and of course we're going to try and see you as soon as you call. Generally, if you call the office, we're going to see you that day, the next day, as soon as possible. If I'm not here, I'll get one of my colleagues to see you, whatever. This is something that, you know, it's not something we're going to schedule. We know how to squeeze you in whenever you call to get you here as soon as possible. I usually like to see any patient with this kind of diagnosis within a day of you making the call, if not the same day, the next day. So if you think we can help you, please give us a call and we'll try and do our very best. Thanks.